for those insights. Yeah, I think we should move on. We are getting a little backed up now. So it's my pleasure to invite Rohan Chawla to speak to us on micropulse laser in diabetic macular edema. Rohan's an additional professor in AIMS RT Center. So,
I'm unable to hear Rohan. I don't know.
yeah, Rohan,
You are muted.
Can you hear me now?
yeah, but
Yes,
your slides
this is
have
great.
gone off.
Okay. Now can you see the slides?
Yes.
Yeah, sorry. So I'm thankful to Dr. Anand for inviting me to this meeting and Solve Society. So as all of us have been discussing, there's a lot of confusion about subthreshold laser, and I might be adding more to the confusion. But the very purpose of this meeting is that we should have different viewpoints first across, and then we can come to probably some guidelines. So something about subthreshold laser in diabetic macular edema, what has been my experience. So there are no financial disclosures from my side. So we've already gone over the rationale. I won't take much time on it. So basically, we are trying to avoid the thermal damage and apply the minimal laser irradiance and also allow for some cooling time. And why we just don't reduce the energy, and why do we add also the apart from the duty cycle, why have we reduced the duration also? Because there is a risk of this micro explosions if we do not reduce the pulse. So that is the additional thing. Not just the energy amount is reduced, but the energy pulse is also reduced. And as we have also discussed that there are various treatment options for DME, focal and grid laser and anti-VEGF agents. And a protocol I has shown that maybe the adjunctive laser may not add to the benefit, but it reduces the intravitreal injections. And probably that is what is our again aim with the subthreshold laser, to reduce the number of injections, as was mentioned in the first talk today. So which laser also we have had a small discussion. So now people are mostly moving towards 577 nanometers. So regarding DME, there have been a lot of publications. I think a lot of people on the panel here have some of these. I've just mentioned quite some of them. There are a lot more. To summarize quickly, what are the key points from these studies, which I found was that when we compare to conventional laser, there is an effect on central macular thickness with about 10 to 12% reduction, similar to conventional laser, and no scarring is seen. And this effect is definitely more if the edema is 400 or less. If it is much more advanced edema, then the effect is less. But again, the laser energy duty cycle cutoff varies across the studies. So how do we decide the cutoff? So from when I started doing laser, I went to this animal study where they found that no damage could be seen if the energy level was kept less than 30%. If it was kept between 30 to 50%, then there was some damage to the retinal pigment epithelium visible on electron microscopy, but again, healing was subsequently seen. So, but they found that less than 30%, there was no effect at all, not visible on any of our imaging modalities, as well as on electron microscopy. This is an animal study. So we also did a small study to study the effect of subthreshold laser on diabetic macular edema. But for the ethics approval, currently we cannot do away with the standard, what is the standard therapy, that is the anti-VEGF therapy. So we took patients who had already undergone some amount of anti-VEGFs and were still non-resolving, and we compared two protocols. In one we used 5% duty cycle, and in the other we used 10% duty cycle. But here I did not use half the energy was more. So actual terms, the 5% was delivering 10%, and the 10% duty cycle protocol was actually delivering around 20%. But still, I was well below the 30% cutoff, which I showed you in the previous study. So I have given a test spot not in the micropulse mode. So this is something learning from me from this webinar. In future, probably I would now try to do the test burn with the subthreshold micropulse mode itself. And like I told you, So sorry, it was 5% and 15%, but we had doubled the power. So actually it became 10% and 30%. And we applied this laser in sort of a grid pattern. So since I'm using a higher power, I was not going subfoveal here. And I repeated the same pattern at least twice in most of the patients. So like I said, we involved patients who had non-resolving edema for at least 3 months, despite more than or equal to 3 intravitreal anti-VEGF injections. And we had a follow-up done after 3 months of our subthreshold laser. So these are the basic parameters which we used. And we also did some quantification of hard exudates, which I'll come to later. So in our study, we did not find a significant change of best corrected visual acuity between the two groups. The central macular thickness did reduce, but it was not statistically significant. We also counted the hard exudate pixels, which I'll just show you how. Now, this did show a statistically significant reduction. And in the other group in which we had lesser energy, there also the hard exudate count did reduce, but the central macular thickness, unfortunately, rather increased. So just to show you an example, so you see the pre-laser photograph where you can see the hard exudates, and the post-laser, even just on the color photograph, you can make out that there is a significant reduction in the hard exudates, though the central macular thickness overall in the study did reduce with the higher power, but it was not statistically significant. So this is a technique we devised where we did some image modifications using image J, using some filters, and then thresholding algorithms where we could highlight these hard exudates much better and count each pixel. And so you can have a pre-laser pixel count and you can have a post-laser pixel count, and then you can do an appropriate statistical analysis. And so this way we found that, yes, definitely the hard exudates reduction was much more marked in our study than the central macular thickness reduction. So the conclusions I would say were that definitely there was no visible laser induced damage. We also did autofluorescence for that, and we did not see any damage in that. But we had taken resistant cases. So perhaps these cases were already resistant. That is why we did not find much gain in visual acuity and not a very significant reduction in CMT. But like I said, we definitely found a reduction in hard exudates. And so again, I think using these lasers, as our main aim is to reduce the number of injections, our thought process probably has to change a little. Yes, probably this laser will never match the efficacy of an anti-VEGF agent. But in many cases, is total drying necessary in diabetic macular edema is something which we have to consider. Perhaps a little bit of few cysts remaining there, and still if the patient is maintaining a visual acuity, the hard exudates are reducing, and the subsequent follow-up does not show an increase in central macular thickness, would also be probably an appropriate therapy for such patients, like we used to be doing earlier when we used to be doing conventional laser, and at that time we did not have OCT. So even at that time, probably after the laser, even in the patients who benefited, probably had we had OCT on that time, at that time, some cystic edema would have been present. So I think that thought process somewhere has to come in to reduce the number of injections and still maintain a significant good visual acuity for our patients. So we are planning further studies where we are planning to compare it for focally, not just in a grid fashion. And also we're trying to improve on our protocol for quantifying these hard exudates. So definitely, I think it has a role. And yes, with such webinars and such many more papers, we would finally be able to narrow down to a particular protocol and when not to use this laser as an adjunct to probably other therapies such as anti-VEGFs and steroids. Thank you. Thank you for a patient hearing.
Excellent. Thank you so much, Dr. Rohan Chawla. It's very nice and very interesting to see the resolution of hard exudates as well, which becomes one of the important parameters in various treatment modalities. Any quick question, comments?
Rohan, are you repeating in the same area second time the grid, dense grid?
Yes. So like I said, I did not, in this study for the grid, I did not do transfoveal. It was like a modified ETDRS grid, but I placed the spots twice.
Okay, even I am doing that in a DME. Any recommendation, Jay, regarding repeat grid on the same area?
Very interesting question, and this is where I particularly feel Nevelas plays a very interesting role, because in Neville, with the help of Nevelas, you are actually able to document where exactly you did the laser. I I don't think there is any harm in repeating at the same spot. But I think at the same time, what we were discussing earlier plays an important role, that because if you really understand the concept of this subthreshold laser, you are not having any heat dissipation in the surrounding area. The adjacent area is not going to have the increase in temperature. That's why you are still able to, you should be actually able to perform the laser adjacent to each other. So I think if we start doing continuous, I should not use the word continuous, but I should say that if we start doing the laser without any spacing, then probably doing the laser at the same areas may not be required.
So
But I
we
don't
don't
think,
have, sorry. So we don't have navilas, but I used a grid pattern of say 4 spots or 8 spots, and then placed them very adjacent to each other, and then repeated the whole thing again with the
yeah,
same
and
settings.
yeah, and I agree completely. And while we were setting up these guidelines, we definitely had this in mind, that not everybody is going to have the documentation of the laser, particularly the subthreshold laser, where you could not see the laser scars. But by doing this, adjacent spots, repeating at the same areas, you may be having greater outcomes. I think we are really running out of time. I'll just quickly jump on to Raja. He has been quiet since the beginning of the webinar. Raja, quick comment on DME, your experience.
I just want to say I've been thoroughly enjoying all the presentations. It's like I feel we should have more time probably to discuss more nitty-gritties, because ultimately we have to give to the audience and ourselves, how do we move forward? What to take home, what exactly, is there enough evidence to say that okay, in these diseases we will move forward and these are the recommendations. But what I'm saying is that at least from Rohan's presentation, and Anand can probably add, from a mild study of micropulse laser, where we used 577 Texel Firedex, where we had two protocols, 4 arms, laser alone, micropulse versus the continuous wave, and also anti-VEGF arm, where we had anti-VEGF with laser and only anti-VEGF alone. From that particular data, although we could not complete the study because of Avastin issues at that time, I would probably at this point of time say convincingly that I am not doing micropulse laser in DME, given that anti-VEGF for the visual acuity benefit. Let's say if you have protocol T, aflibercept, the kind of gain you are going to get with the vision versus a micropulse alone. I mean, one message at least clear cut I can tell the audience is that don't think of it as a substitute for anti-VEGF. And I like what Rohan also mentioned in his conclusions. What we're looking for is a laser, maybe a conventional laser versus a micropulse laser. Can it reduce the requirement for engineering? And that's where Ken had started off his initial discussion itself. And I think that is something we certainly should look forward to going forward. Unfortunately, we could not complete that study from that particular angle. And also from CSR, I'm in favor of doing a bigger RCT and prove that based on these settings, it is either non-inferior to PDT. At this time, we are not having PDT in India. And that's a big concern. And it's also more cost effective, easier to do. So if we can do and prove it in a proper RCT, that's what we have to tell the audience also, that, I think it's promising. And there are some at least take homes that we can give the audience.
Yeah, I'll just quickly add that, yeah, I totally agree with Raja. We could not, bring that study to fruition. But I just also like to add 2 things. One is the USP of this modality is that you can do repeat treatment. And that is the USP. You can go over the phobia, you can go transfoveal, you can go over those areas. And it's exciting to see what Rohan did, which is a really standout thing, is that the RX rates actually reduced. That's one. Second thing I'd just like to highlight, there was a publication in the IGO from a Turkish group a couple of years back, where they compared aflibercept, PRN, loading dose, 3 doses, and then PRN versus combination, 3 injections aflibercept and micropulse laser, and they found that it was more or less the same, but the number of injections were reduced with the combination. So